So welcome everyone. Thank you very much for taking time out to attend this panel discussion, COVID-19 in Africa, a critical discussion. This is part of a series of events, as many of you will know, as part of King's Africa Week that began on Monday. And there'll be more events throughout the rest of the week. There was one just before our panel, actually hosted by the African Leadership Centre, a critical discussion as well around COVID-19 and a lot of research that some African Leadership Centre fellows have been doing. This particular event is hosted by the Africa Research Group, Department of War Studies. But as always, a lot of the stress that we want to keep on Africa Week is the amount of work that's going on across King's and across our partners in Africa is really interdisciplinary, multidisciplinary, and there's lots of really important, interesting work going on. So before I introduce our panelists and we get down to it, I just want to make a couple of points about the thematic interest and how this fits in the rest of the week and what we've had so far. First of all, and we were just discussing this actually before we came live, there's been a really interesting engagement this week around the kind of the tropes around the way Africa is reported on, the way Africa is talked about in even academic discussions. We've seen over the last 20, 30 years, both negative, kind of the hopeless continent discourses, and also very, very positive Africa rising discourses, both of which are problematic in the sense that they tend to ignore the nuances and the sheer variety that exists across 54 countries in a huge continent. And so the story of COVID-19 in Africa and health challenges in Africa can't be so simplistic as this. So one of the things that we've looked at throughout this whole week is thinking about how we talk about COVID-19 in relation to the African experience and also African expertise. And on that second point on African expertise, we've also been thinking about how structures of knowledge exist. What information is circulated about COVID-19 within Africa, but also from Africa and from African scholars and African experts? Is it easy for that information to travel from Africa outside to the rest of the world, or does it only go one way? What publishing barriers, what practical barriers exist, economic barriers for gaining the knowledge and experience from within Africa and sharing that more globally? And then thirdly, and linked to a lot of the expertise on this panel as well, what's the value of research collaborations? What's the value of organizations like King's and our very many partners in working together with African colleagues and building up these kind of research partnerships? What can we do? So we have three excellent speakers who can certainly talk about all of these points and many more. And I will introduce them all now, and then we'll have the presentations or the kind of introductory remarks really one after the other. So first of all, I'll introduce Lara. So Lara Fairall, thank you for joining us. Lara is a professor of healthcare delivery at the Global Health Institute at King's College London, and she's the founding director of the Knowledge Translation Unit at the University of Cape Town. Lara will tell you more about her work, but it's doing a really interesting thing on providing guidelines for care and information on healthcare across Africa. We're also joined by Obi Sisay, OBE, who's the former director of the Situation Room in Sierra Leone's National Ebola Response Centre, and is currently the the Gambia country head and senior global COVID-19 advisor at the Tony Blair Institute for Global Change. And again, Obi is, other than his existing role, has a lot of experience, particularly in response to the Ebola outbreak in West Africa and specifically in Sierra Leone. And then finally, Martin Prince is Professor of Epidemiological Psychiatry at King's College London. He's also Assistant Principal at King's of Global Health and the Director of the King's Global Health Institute. And I'm going to ask Martin to start us off, followed by Obi, and then finally with Lara. After this, you will have opportunity to ask questions. If you have them, if you can put them in the Q&A box, you should see there's an opportunity to put your questions into that. I'll have maybe a few questions for our panelists after they've spoken, and then we'll hopefully have opportunity to have some discussion with those people asking questions. So without further ado, Martin, thank you very much for joining us, and over to you.
So thanks very much, Kieran. So I guess my role on this panel is mainly justified really through the work that we've been doing at King's Global Health Institute on the pandemic in the 46 sub-Saharan African countries. And we started this at the end of March. The first case in sub-Saharan Africa was identified in Nigeria on the 28th of February of this year. But already by the first few weeks in April, all 46 countries had actually reported cases. So the initial spread across the region was really rapid. And there were a lot of concerns that were being expressed at that time about how this would all pan out in sub-Saharan Africa. There was a perception that there was a particular lack of pandemic preparedness amongst sub-Saharan African countries. There were concerns that were largely justified around testing capacity, infrastructure, and whether or not there would be the potential to kind of scale up testing should epidemics grow in the way that they had done in high-income countries in Europe and North America. There were particular concerns about mortality from COVID-19 due to the high prevalence of underlying morbidities, the obvious potential increased risk for people living with HIV, TB, and the lack of critical care facilities that had been known about for a long time in sub-Saharan African countries. But this was one particular area where health system strengthening had been relatively slow to develop. So very few intensive care unit beds, poor oxygen, poor limited oxygen supplies, few concentrators, few ventilators. So there seemed to be a particular need to have a focus on these 46 countries. That's what we set out to do. Since the end of March, we've been looking at the figures provided by the European CDC. We've been downloading those on a daily basis. We've been processing them. We produce regular daily updates on the cumulative number of new cases and deaths for the 46 countries as a whole, for the sub-regions, Western, Southern, Central, and Eastern. And then look at the trajectories across the 46 countries. And we then started looking in much more detail at 19 countries, initially from the point of view of testing, because the Ministry of Health reports were particularly detailed. They provided daily accounts of the numbers of tests conducted, the proportion of those that were positive. But we swiftly realized that actually there was a whole wealth of information in these reports around, for example, the sub-regional distribution in countries like South Africa, the province by province, case numbers, hospitalization rates, and case fatality rates as well. So what we've learned from this in brief, now, as of today, there have been 1.2 million cases of COVID-19 reported across the 46 countries and 27,000 deaths. Now, given that the population of these 46 countries together slightly exceeds 1 billion, that's 14% of the world's population, actually, these are fairly light case loads. 1.2 million cases is 3.5% of the global total, but that's for 14% of the population. The 27,000 deaths are 2.4% of the global total of deaths for 14% of the population. And the case fatality risk doesn't vary much. It's now stabilizing across most of these countries. It's around 2% or just over, and that's a relatively low case fatality risk as well. Of course, these are youthful populations, and we've seen that the greatest concentration of deaths in COVID-19 is very much amongst the middle-aged and older populations with complex comorbidities. And so that's undoubtedly one of the factors. But the feared tide of mortality that was kind of expected because the limited critical care capacity in many of these countries, I think we can say is not eventuated. Now, what's happened looking at the figures for the 46 countries combined is that new cases peaked in mid-July. And at that time, one country, South Africa, had actually contributed pretty much 75 to 80% of all of the cases that have been recorded in the region. And that was when South Africa's incident cases peaked. And after that, there was a rapid decline. Now, what we've discovered from this is that really the only way that makes sense of looking at this across these sub-Saharan African countries, given their very variable testing capacity, is to look at trajectories. And so what we've come up with is a very simple classification of the numbers going up, that's rising. Have the numbers peaked? And we've got a pretty conservative definition of that. To be peaked, you need to be at least 50% below your peak weekly case count, and that needs to have been maintained for at least 3 weeks. On that basis, of the 46 sub-Saharan African countries, we're now classifying 36 of them. That's more than 3/4, nearly 4/5, as having peaked. And those countries that have peaked, the very large majority of them have stayed peaked. And they've stayed peaked now for 2.5 up to 3 months. And there's very little evidence of resurgent transmission within these countries. So across the region, we've reached what I would call a trough of low endemicity. So what this means is that the R number is well below 1. We're seeing roughly 4,000 cases per day across all of the countries combined. And in South Africa, we're seeing less than 2,000, an average of about 1,800 cases a day. I suspect that this is as low as it gets. That's what happens with low endemicity. We're not going to get, until we get a vaccine or until this just all goes away, we're not going to get a lower daily case level than what we're perceiving at the moment. And when you have low endemicity, of course it can come back. There was a BBC reality check issued just last week, where on the basis of just a slight increase in numbers across sub-Saharan Africa in 1 week, the BBC were raising concerns about a resurgence of cases, huge rises in deaths in sub-Saharan Africa. And as we pointed out in a slightly combative post that week, this is absolutely not the case. The evidence just simply does not show this. At the moment, we're seeing exponential growth still in just 3 countries, Angola, Botswana, and the tiny island populations of Cabo Verde off the west coast. And we're still seeing quite active and large numbers from Ethiopia and Uganda, but the transmission rates have gone down there, and it could well be things are coming under control. As far as resurgence is concerned, there's very little evidence of this. The one that I would draw attention to is that Kenya, that had been showing exponential growth, then seemed to have peaked. They seem now to be returning to exponential growth as well, and that needs a bit more investigation. So I think the questions that I would be interested in raising and hearing people's views on are, is it really true that the caseload is as low as it seems to be? My view is that, of course, all around the world, the true numbers have been underestimated because of limited testing capacity. That's probably slightly more the case in the sub-Saharan African countries. But I think in general, the fact that this has been a light outbreak, and in my view, well managed, is supported by the data, and this needs to be acknowledged, and we need to learn from that experience. We need to look at the South Africa story and why exactly it was that at peak 80% of all of the cases in the region were coming from South Africa. What were the explanations behind that? I've certainly got some thoughts on that one. Because of the problems with procurement of tests and delivering testing capacity across the region, it's really important that I think we discuss global inequities, the way that sub-Saharan African countries were effectively shut out of what rapidly became a highly competitive global market for not only testing materials, but I think in a way, even more importantly, personal protective equipment, which is a hugely important part of the response, and what that will all mean in a future world in which vaccines that might be effective might become available, and how we're going to be distributing those. Above all, I think we need to talk about health systems and the importance of health systems in the overall management of this outbreak. And the way that I would kind of break this down really is the control measures that have been deployed in sub-Saharan African countries. I think there's a huge amount of learning from that. The very early application of border closures and quarantine that we were very slow on in high-income countries, the rapid banning on mass gatherings, school closures, limiting on certain businesses. Very few actual lockdowns in the Western sense were applied in sub-Saharan African countries. For very good reasons, because governments and leaders recognized, I think at a very early stage, that this was just not going to be feasible, that the economic outcomes of doing that were really very difficult to mitigate and were likely to be of more harm than they would benefit within the kind of disease control profile. But I think what African countries did use, which are very traditional measures of curfews and cordons sanitaires and limitations on interprovincial travel, were probably really important. And then the other thing is the effort, the application and the energy and the community resources through community health workers that had always existed and were well trained in infection prevention and control measures. There really ought to be still learning in high-income countries about the way in which that effort and the persistence of that effort over time has been, in my view, such an important feature of the control in outbreaks in these countries, which, due to the level of development in the countries concerned, their low levels of urbanization and the low population densities in many of the areas, have been very patchy with a lot of hotspots. So the clustering of the infection has been appreciated by the public health authorities, and they've built that into the control measures, in particular into the testing, isolating programs to try and wrap up hotspots rapidly when they appear. So those are most of the things that I wanted to kind of prefigure as areas of interest, in particular around the South-North learning that I think is so important in this area.
Thank you so much, Martin. That's really interesting to hear. Yeah, South-North learning and challenges, but also some of the positives that perhaps we don't always hear of them. Obi, finish that coffee. It's your turn.
Right. So hello, Kieran. Thanks for having me. As you say, my name is Obi Sisay. Now, I am not an expert in public health. I don't have a background in medicine or public health. And so I'm not really here to speak to those expert topics. My two colleagues on the panel are probably far more qualified to do this. My background is in information management and analysis and risk forecasting and analysis. Indeed, that's how I come to know you, Kieran. When the Ebola outbreak broke out in West Africa, we understood very quickly that you can learn how to sequence the DNA of Ebola at medical school. You can learn how to write policies in the civil service and in a think tank. But what you don't learn is how to mount the sorts of operations that you need to counter a viral epidemic. What we used to say at the National Ebola Response Center was, to fight Ebola, we need a brain and a brawn. The brain being the medical expert knowledge that guides everything that you do. The brawn being the organizational and strategic and tactical skills to be able to launch what you do. Now, at the Tony Blair Institute, what we do is we support leaders by providing them advice, by providing them capacity to help them to improve the human condition of their people. Now, often we would work in the center of government, in the presidency or prime minister's office, and we will also work in the periphery in various departments, all being to help people to come and organize and make evidence-based decisions that can be implemented and monitored. Now, when the Ebola outbreak broke up in Sierra Leone, indeed, the reason I'm working for the Tony Blair Institute now is when the Ebola outbreak broke out in Sierra Leone, I was, as director of the situation, faced with an environment where we did not have a culture of well-functioning government institutions. The Tony Blair Institute gave me some free advisors that were very crucial towards helping us design and plan critical interventions to end that outbreak. And so, in a sense, me working for them now is a sort of payback to say thank you for what they did for my country, and to also support them in their ambitions for the rest of Africa. We're currently working around 13 African countries. We might probably increase that. Now, my issue that I want to raise really is what I would call effortless condescension. When this outbreak started, we published an article, an opinion piece in February, where we pretty much laid out exactly what was going to happen with COVID, right down to infections at hospitals before we had the case in the DC. There are two things that you cannot control, that you can control. When you have a virus that you don't have a cure for, there are two things that you can control. One is the fact that the virus needs humans to infect each other. The second is your operational readiness and capabilities to respond to it. In terms of humans infecting humans, we have to understand that behavioral change is central to this. The problem I see as I look around the world, and indeed we've commented about this, when they started talking about lockdowns, we practically invented and perfected lockdowns in West Africa for Ebola. But we knew what we were doing in the sense that we knew what they could and couldn't do. Lockdowns are a tactical solution. They are not a strategic solution. And indeed, we have been saying for a long time, as soon as they lift lockdowns, we will start to see cases rising up again. And that is indeed what we have seen. That is because there's a fundamental misunderstanding of the role that the human being plays. It seems like an intractable problem when you have a virus that you don't have a cure for, until you get the holy grail, which is to understand that the virus needs you to infect each other. That is the first thing that you can control. And that relies on information. First of all, information to the public about what the virus is, how they get infected, how they can infect others, what they can do to minimize their chances of being infected and to infect others. When this whole thing started, we were pretty aghast watching what was going on. It is almost as if those who were supposed to own the knowledge abandoned the battlefield of information. Coronavirus conspiracy theories were flying all over the place. Social media, the internet had already taken control. Now, I ask this question. If as a society, humanity, we are able to convince people to change their lifestyles, we are able to convince people to buy things they don't need, we're able and go into debt to do this, we're able to convince people to eat foods, why are we not able to convince them to change their behavior to save their own lives? Have we gone about it right? The message and the messenger and the mediums we use are incredibly important, because influencing human behavior determines whether people will obey public health messages. It determines whether people will infect each other. In the beginning of the outbreak, what we found was that most infections were happening at home. And so then you have to step back from an intellectual perspective and say, so what's the quarantine? And then when you look at the approaches towards contact tracing, a lot of it was based around human proximity in public, failing to understand that it is not the pavements that carry the virus. It is the people that walk on the pavements. What are we doing to influence people's behavior? There are certain specialties that various people have. Psychologists and psychiatrists and marketers are specialists in influencing human behavior. Doctors are specialists in managing cases, case management. Logistics companies and the army are specialists in logistics and moving things from A to B and organizing things ship, sharp, shape. We have not used the broad spectrum of expertise that we have. The messengers and the messages that we have used to combat COVID have been very, very poor. Now, when you look at the information as well, there's a question not just about what you disseminate to the public. There's also a question about what you measure, what matters, and how do you share it with various people involved in the operational response? How quickly do you share it? How reliable is that information? Once you've dealt with information in terms of human behavior and in terms of the input it has towards your operational response, the next key thing that you can control in a viral epidemic that you don't have a cure for is your operational readiness. How many PPEs do you have? What is your turnaround time for samples? How well are you doing contact tracing? When you juxtapose the African response to COVID and the Western and perhaps possibly global response to COVID, what you'll find is that in Africa, we moved quickly because we had some experience. Many countries closed borders early. Many countries restricted inter-district travel very, very early. And many countries aggressively did not just trace contacts, they monitored and followed them. Contact tracing is the holy grail in a viral epidemic. Who gave it to whom? Whether it's at the start, the middle, or at the end, unless you start to really narrow down, I call it find, fix, and eradicate. We started saying test and trace and test and track, and now it's become a global term. But understanding who gave it to who is the only way you're going to be able to finally narrow down, fix, and eradicate those chains of transmission of your virus. Now, in the beginning of your epidemic, you're usually able to do very good contact tracing because you have only a few people have it. In Africa, very quickly, mostly in places, they moved very fast to identify those index cases and try to contain it. Yes, they did not manage to stop the virus spreading. Yes, they did not stop community spread setting in, but however, they had some control of the initial takeoff point of the virus. When you're in the middle of your epidemiological and you have cases popping all over the place, it is much harder to do contact tracing, but you must not stop. Because the whole point of contact tracing is to isolate the virus from the human population. Even with a virus that is not as deadly as Ebola, i.e. COVID, every time you do contact tracing, it might seem like a needle in a haystack problem, but you are still doing something to fight against the virus. As we move towards the end of the epidemiological curve, you're only going to end it when you start to granularly narrow down your chains of transmission. Contact tracing around the world has been very scattered in terms of its seriousness. In the UK, it has not been very, very good, and in many parts of the world, ditto. What you need to understand is that unless and until you are able to stop people infecting each other, and unless and until you are able to identify who has infected each other, and until you're able to stop people infecting each other, you still have a problem. If you find 9 contacts, one of the expressions I like to use is that fighting a viral epidemic of this sort is like fetching water with a basket. If you find 9 contacts of an Ebola patient or COVID positive person and you miss one, you still have an epidemic because you started with just one. That is quite a sobering thought. The other thing also to point out are the key differences between Ebola and COVID. In the case of Ebola, you tend to infect your nearest and dearest, the people who touch you, who touch your fluids. But a COVID positive patient can infect 10 people in one city, one at each end and the other 8 in between, all because they congregated at one bar. An Ebola patient is not usually able, when they're infectious, to go to bars. This means that the nature of contact tracing and viral response that you need to do to both viruses are very, very different. You learn lessons from one, but you must understand, they say we learn how to fight the next war by studying the last war, but we must also know that the next war is going to be nothing like the last war. We have technology now beyond Ebola that should allow us to do this. But you cannot replace technology with the hardcore epidemiological and scientific work that my 2 colleagues on the panel do, that difficult legwork. You have to convince communities to believe what you're telling them. If you have misinformation crossing from left, right, and center, and you lose that essential element of public trust, you have lost the most vital aspect of your viral response, which is human behavior. Now, one of the key things as well with Africa has been the fact that we have been able in Africa to marshal community support. We've been able to marshal private sector in a way that has not been done, or I have not seen so far in the West. In Nigeria, for example, there's a whole coalition of the private sector that has worked. In many African countries, community mobilizers, community workers, families, communities have been very engaged and involved in the response. Over here in the West, I'm currently in London, but over here in the West, COVID is seen as a government problem. It's not seen as a community problem. It's not seen as a social problem. And the interventions that they have come up with are all very, very, what I call mechanical. The purpose of a lockdown is to limit human interaction. But if the humans don't understand why you're limiting their interaction, the minute you lift the lockdowns, they're going to congregate in bars and start infecting each other again. So that first test, in my view, there are three strategic realities that any policymaker that wants to fight a viral response has to understand when you don't have a cure. And these strategic realities you need to write on a whiteboard each and every time you sit down to discuss your viral response, which is number one. This is not going to end until either everyone is infected or you have herd immunity. Number two, you invent a vaccine. Number three, you invent a cure. These are the three strategic realities. And you have to understand those as you go through the phases of your response. The other thing to understand also is that treat your enemy with respect. During Ebola, we gave a name in my situation room to the virus. We called her the lady. And we said that we were on a dance with the lady. The reason for this is because what you find with a virus that is unknown to science and to yourselves is that all your old assumptions start to fall apart as you go through. And what you also start to learn, and the scientists tell you, is that as you start interacting with the virus, it is almost as if it can react to what you're doing. So first we thought that once you got COVID, you would not get it again. Now we're hearing about cases of people having COVID again. First we thought that it couldn't spread so far through the air. Now we're finding that is, so to me, it is almost as if we dance with the virus. And until we learn the steps of the dance, the virus imposes discipline upon us. Until we learn the steps of that dance to the point where we can lead the virus in the dance, we do not have a chance of being on top when the music stops, of having a cheer. This is one of the key challenges that I see with policymaking failures in terms of response to the virus. It brings me next on to vaccines. So first of all, like I said, you have to be on top of your information, convincing the public and knowing what information to collect and how to deploy that in your response. Secondly, your operational preparedness has to be on point. Your turnaround times for your tests, your availabilities of PPE, your supply chains, your logistics, your frontline healthcare workers, protecting them, supplying them. These things have to be there. Quarantine monitoring. You don't just put people in quarantine, you need to check. I was speaking to a colleague who traveled to the US very recently. And this colleague landed up in the US and there was nobody to even pick up the COVID form that she had filled. Somebody was supposed to take a temperature, nobody did. Now, if you go to Africa today, that's not happening. In many African countries, you don't land there unless you've been tested for COVID. And we are very, very stringent about it. I think the world has a lot to learn from Africa when it comes to viral response. Now, we now come to the solutions. So we're talking about vaccines. My colleague just spoke about vaccines. What we will find is that there's very few vaccine trials going on in Africa. I think the scientists will tell you that this is extremely dangerous from a medical perspective. Human DNA varies in various places, even between villages. And so if vaccines are not tested in Africa, there is a strong risk that the COVID vaccine developed will not have efficacy in many parts or some parts of Africa. Now, this is a very difficult question to answer because there is a lot of conspiracy theory around vaccines. There's a lot of bad science and there's a lot of conspiracy theory. In the UK, we are now dealing with the effects of people who had been scared of giving their children the measles, mumps, and rubella vaccine. Those children are now growing up and we're seeing the consequences of that. So there's a lot of noise, like I would call it, around vaccines. And this is one of the challenges that we have to face. But the second challenge, again, along these lines of effortless condescension, is that the current model for public health for vaccine provision for Africa relies on Africa being given vaccines. Africa is not necessarily included in the development and production of these vaccines. Now, my argument is that this needs to change, both for global health. In the new global health architecture that we face, this needs to change, but also because we need to understand that we're only as strong as our weakest link. If you don't share your riches with the poor will share their poverty with you. What COVID has taught us is that you are not safe, even if you are the president of America, from a virus that may have developed in a market in China. We're an interconnected and global world. People who are responding to viral epidemics need to listen to the experts, like my two colleagues who are here on the panel. They need to be led by expert information and expert guidance. And they need to understand that they need to bring communities with them. They need to bring the public with them. And that means that they need to have credibility and they need to have purpose. Nobody knows anything about COVID, so you will make mistakes. Run to problems, do not run from them. Don't lie to the public. When you mess up, tell them you've messed up and why you have messed up. Then it becomes a problem shared. Otherwise, as we find in many parts of the West, people are waiting for the government to solve the COVID problem, and that is not going to happen. As we develop vaccines, we must include Africa, and we must bring Africa with us. Even as we respond to the virus, we must learn from Africa. We must stop this effortless condescension. That's enough from me.
Brilliant. Thanks so much, Obi. It's really, really comprehensive, and there's so much to get into there. Safe comments and questions until a little bit later, but thank you very much. Finally, Lara is going to talk to us now, and Lara has some slides to share and a lot of direct experience, particularly in South Africa, which has already been mentioned a lot. So thank you very much, Lara, for joining us.
Thank you very much for those comments. So here is a community health worker in action in one of our townships in Cape Town, carrying materials to people, delivering them to their doors in very difficult circumstances. So this really just illustrates, I think, just this enormous community response that we've had to COVID-19 in the region. And I suppose we've also had more well-developed community resources and networks to tap on in that time. So my background is that, just trying to get this to go to the next slide. Let's see. Is that I lead a program called the Practical Approach to Care Kit, or PAC, which over the last 20 years has looked at empowering frontline providers of healthcare with clinical decision support, which is evidence-informed, comprehensive, matches the way that patients present to primary care, which is not with diagnoses, but with symptoms, and is highly localized to available resources and policies in countries, and implemented through evidence-based implementation methods. And this has been shown in several trials from South Africa and one from Brazil to result in consistent but modest improvements across a range of primary care behaviors, across a range of conditions. No headline news, but a real overall strength in the way that primary care is provided, so that it's more in line with evidence-informed care. And there's some resources where you can go and read more about our program. So during the COVID pandemic, we really expanded in several instances. So the first one was very, very natural, because we have focused largely on primary care content for adults over the last 20 years. And so we immediately put together simplified algorithms and checklists to manage people presenting to primary care. And this was despite the almost non-existence of any primary care response in high-income countries. It was very hospital-centric. Our screens were flooded with images of intensive care, ventilators, etc. And really the role of primary care had been completely underlooked, especially in a condition which for most part actually could be successfully managed at community level. And what was, I think, different about our guidance is that from the get-go, we really adopted a much more African approach to the problem, in that we acknowledge that it doesn't matter whether we get told to test, the tests may not be universally available. So we need to have a plan for where tests are not available or for where PPE is not available. So we really embraced that from the start. We then also extended our materials very materially into community content because there was actually a lot of messaging, a lot of misinformation, a lot of information, but not very clinically curated information that was organized across primary care, hospital care, and communities. And this was particularly important in South Africa and in the region in which I live, where we had a data-driven response, which identified that in fact, our profile for risk was in fact in slightly younger adults than what you were seeing in the north, so in people older than age than 55 rather than 70, and particular groups like people living with diabetes were particularly affected. So we really focused on targeting those groups to get them to go for early testing and to be enrolled into services. We then extended the content into inpatient care because a lot of people were finding themselves operating outside of their zone of comfort during this time, and they needed really clear support. And I think the one notable of COVID has been, I don't think I've ever seen a guideline dissemination event via WhatsApp as I've seen with COVID, but certainly WhatsApp became the primary way in which healthcare workers around the world were accessing new content, which is highly unusual. We focus usually on face-to-face training, which is very typical in Africa, but we had no choice but to move this into an online environment. And many of our clinicians are not used to, especially our non-physicians, to working in an online environment. And I'm going to touch on that a little bit later. So most of our content is available, and I've put some links in there if you're interested in seeing any more. So I already have 3 reflections, which is to really emphasize the importance of the primary healthcare response during a pandemic, and especially a pandemic which was very much focused in high-income countries on hospital-centric and in fact ICU care and provision. And I think we did benefit from the fact that we were slightly behind the global curve, and so we were able to learn lessons from essentially very dismal outcomes in high-income countries and to adopt new treatments and new approaches. So to reduce ventilators, I must say I breathed a huge sigh of relief when realized that ventilation was not going to be the solution to management of severe cases, but really to look at how primary healthcare services play such a vital role in the linkage, particularly in Africa, of linking populations with healthcare services, and that they can manage, they can triage, test, manage non-severe cases, assist with that community contact tracing, and with engagement and communication. I think the one issue that hasn't come up on today's panel so far is just really the need to protect essential healthcare programs. So these were often neglected, early, and very similar to the Ebola response. We saw dramatic reductions in childhood immunization, in HIV and tuberculosis care. And bear in mind that while Ebola has abated, we're very much in the throes of 2 slow burn pandemics in the region, both HIV and TB, which have been of great concern to us as a service. So we really felt this pressing need to be able to attend to those priorities at the same time. And there are many estimates that suggest that the number of deaths and morbidity that are going to result from these conditions are going to way exceed that of COVID in the region. And then obviously primary healthcare is the vehicle for vaccination delivery ultimately. And so it does need to be invested in and strengthened ultimately if vaccination is going to be used to contain the pandemic. So these are some examples of our content that is available in editable templates, which really looks at our much more comprehensive approach. So including not only COVID, but also looking at conditions like tuberculosis and immunization from the get-go, and realizing that we need to really communicate that those services are safe to be engaged with. They must continue to be engaged with if we are to prevent follow-on pandemics in those areas. The second learning for me was the ability to leverage what I've termed the education subsystem within the healthcare system in the region and the partnerships. So prior to COVID, we were working in the 3 largest African countries in sub-Saharan Africa, as well as in Brazil. And we were very rapidly, with primary healthcare content, and here's some examples, and we were very rapidly able to leverage those relationships and networks to disseminate COVID material and share some of our resources and open up training and responsibilities. And particularly in Ethiopia and in South Africa, but also in Brazil, outside of the region. And we also, through a King's partnership, we're also able to provide some assistance to Somaliland. So that was a new partner. And that was really novel for me because it really worked on the premise that without meeting people and without having face-to-face meetings, it was almost impossible to do this work in the region. And I think we've seen a complete change in communities of practice globally, but also in the region, where it has been possible to even not only to leverage existing relationships, but to form new relationships that can deliver solutions that are locally relevant to the setting. And these are some of the versions of our content that have been used in other areas. And then the last piece that I wanted to touch on, which I think is an issue that is unique to the region, is just to really to highlight just the really poor connectivity in sub-Saharan Africa and the data divide in our population. And access to information is absolutely key to containing a pandemic. But if we don't increase or address the barriers to accessing that information, we are going to fail. And I think, it comes to shock us to some people as that some of our challenges, for example, in South Africa around connectivity are related to the extremely high cost of data in our country, which is many-fold that of in Europe, and to some really, what feels like really old-fashioned sort of logistics, in that there's a cable under the sea in the Atlantic that actually connects most of Africa to the internet. And that cable went down at the start of the pandemic. And we've also had interruptions in our electricity supplies, which are part of another outside of the health sector problem that limit our ability to connect. And this means that for many of our health workers in Africa, they have been excluded systematically by this from more modern ways of engaging in learning and in communities of practice. And some of the work we've done through the ASSET program, which is led by KGHI, is to look at how we can reconfigure what we had planned to do, which is to strengthen TB diagnosis in a rural district in South Africa, to actually integrate both TB and COVID screening into one package, but to do so in a way that allowed people who were excluded from this world to participate in an online program. So the image in the top right there was taken yesterday morning, and is a group of nurses in a small clinic, which has traditionally battled with their TB care and also with their COVID care in the last few months. And they are receiving training in how to actually, not only in the content, but how to actually start engaging with online training services. And I really wanted to share this quote, which really speaks to this generational divide as well, which is how one of the nurses said that she's felt so empowered by this experience because she's part of a new community now. She's seen her granddaughter attend virtual university sessions, and she's never been able to access on-demand training before. And she's now able to do so. And we're really trying to pay attention to how to bring a wider range of health workers in the region into this. But in order to solve these problems long-term, there is going to be some need to address the connectivity problem in Africa and the high prohibitive cost of data. So I think that I will end there. I think I do want to make one comment about, I think, the role that Africa brings to the global response. And that is to say that in such a resource-poor area of the world, we really are forced to think very innovatively from the get-go and from the start. And so I think the adoption of early limitations of movement and closing borders was really driven by the fact that we were concerned we had a very large, vulnerable population because of our HIV and TB pandemics. In fact, our non-communicable disease population was far more at risk of adverse outcomes. But we were forced to act quickly because we did not have the resources you saw in high-income countries to manage severe disease. So we've had to act definitively. We've adopted universal mask wearing early in April, which I think is the only region outside of Southeast Asia to do so as early as that. So we've had to think innovatively and embrace solutions quickly. And I think that that's been something that we can contribute globally. I am very concerned, as are my two colleagues, about the discourse around vaccines and what that does mean for us. I mean, certainly, I think that we're only really planning on seeing vaccines in this region in a material way in 2022. So we'll be living this for some time. So I think that's it from me.
Thank you very much, Lara. Really great to get the detailed exploration of what you've been doing, and I think particularly getting that stress on the value of community health workers, something that I've seen a lot in South Africa as being one area where it's been an impressive response, just the sheer scale of health workers and being out in the communities as a response. Now, to our audience, it'd be great if you can put your questions into the Q&A box. So just type them in there and we'll get to them. So we have a question already, but I'm just going to make a couple of kind of broad questions that hopefully the panel can just respond to initially. And if our panelists want to respond to things that were raised by any of the other speakers, please also go ahead. So first of all, actually, I'll come to you in a moment, Martin, to kick us off. But one of the things that it'd be good is to hear your thoughts on South Africa and the specific explanation of the data, which you brought up and said you're happy to address. And I think that would be quite interesting to see, why was South Africa seemingly different? Why were the cases concentrated there within the continent? And some of that might have already been kind of covered in what Lara touched on. Secondly, we've heard about the value, the benefits of WhatsApp. Lara, you mentioned about that communication, and you stress just how vital information is. At the same time, we've also had this point that Obi kept making, that we need to listen to the experts and combine that knowledge with also what we do in the area of kind of logistical planning and strategizing. And there's a broader question here, which you are all experts in your fields. Have you found that it has been harder or easier than perhaps it might have been in the past in getting your information out? Because we can improve access to information, but how can we improve the quality of the information that gets out? It's already been mentioned, the problem of fake news, people not necessarily believing that certain things are real, doubting vaccines, worrying, if these trials take place in Africa, that this is a conspiracy. So is there a place for experts themselves to take that on, to challenge the quality of information that gets off, as well as improving the access? Difficult question, because it speaks to the broader political moment that we're in, but I'd be interested to hear your thoughts. And then lastly, and there's more we could talk about, but I'll just leave it there. On the community workers, Lara, that you mentioned, and Obi, you've got that experience in South Africa, and Martin, you mentioned, generally Africa has done very well. Is there something specifically about many African societies that they have a much stronger presence of community health workers? In South Africa is, the history of fighting HIV/AIDS, which has had a really important place in building up that infrastructure, and the Ebola experience in West Africa. Is this something that Western nations, for example, need to address because they haven't necessarily had that kind of experience, or are the societies set up differently so it wouldn't be as appropriate? What's the limits of this lesson, and how how far it can be applied. So please feel free to address that and any other points. If you want to start off, Martin, and then perhaps Lara, and then Obi, and then we'll go to the questions.
Yes, with regard to South Africa, it's something Lara and I have discussed a lot, and I think we're in broad agreement really around what may be the relevant issues here. I think the first thing is that South Africa leads sub-Saharan African nations in terms of its connectivity with the outside world. So if you look at the passenger numbers coming through the major airports in Cape Town, in Gauteng, in Durban, KwaZulu-Natal, you see that they're an order of magnitude greater than any of the other countries. Ethiopia, yes, but that's mostly passengers in transit coming through with Ethiopian Airlines. Much more passenger traffic than in Nigeria as well. So in that initial stage, where by definition these were imported cases, there was just a lot more of them coming through than would have been the case for other sub-Saharan African countries. And actually, although South Africa was pretty quick in closing down its borders, it wasn't as quick as other sub-Saharan African countries. Arguably, the seeding of international cases preceded the first recognition of the first case in Nigeria by, weeks, possibly even months. So that effectively there were a lot of cases already out there in South Africa at the very beginning before these control measures kind of came in. And I think what you then saw in South Africa was interesting because initially the transmission was quite low scale, but quite a lot of it was amongst contacts of these travelers and was in quite kind of high income communities within the major cities. And then there was another phase where province by province transmission took off in the townships in these really high density urban areas. And because transport had effectively been closed down between provinces, there were actually separate outbreaks in Western Cape, in Gauteng, then in KwaZulu-Natal, in Eastern Cape, and you can actually see the kind of classic rise, peaking and then fall of those outbreaks in those regions. So looking at the numbers and why those were so much greater and the attack rates were so much higher than in other sub-Saharan African countries, I think quite a lot of that was because of the volume of testing and the excellence of the contact tracing programs in South Africa in those early stages. So, South Africa at peak was doing 45,000 tests per day. Ethiopia briefly reached 17,000 tests per day. Kenya, Uganda, the other leading countries, Ghana, were somewhat lower than that. And so they were recognizing more cases, but even then at the peak of the outbreak in July, there were 12-day delays in test results being returned. And even South Africa, with their 45,000 tests per day, needed to actually begin to focus on testing kind of high-risk populations and hospital admissions and so on, because the outbreak had completely run away from them. I think interesting data emerging from South Africa, and Lara probably knows more about the specifics of this, is that some seroprevalence surveys that have been carried out. So these are the antibody rapid tests that look at the proportion of the population that have ever been affected with COVID-19, are returning prevalences as high as 50% or even higher from, in particular, the high density urban populations. And so what actually does seem plausible in South Africa is that in these real hotspots, that something approaching herd immunity was possibly realized. Now, there's still large reservoirs of the population that have not been infected, and the possibility for transmission to continue, particularly in rural and more far-flung districts. And as we've heard, immunity may not be particularly long-lasting, and so there's the need to remain vigilant. But I think those are probably among the reasons why South Africa actually stands out so much from among the other sub-Saharan African countries.
Lara.
Yeah, so absolutely. I do think we have a huge amount of travel, and it did hit us during our peak tourist season. We also had a mega event in Cape Town, which I think was explained one of the reasons we had such a big peak in the Western Cape, or we were the first province to really get going. We had the world's largest timed cycle tour on the 8th of March, which was 2 days after our first case. There is a lot of travel and commuting. I think the seroprevalence data is interesting. I would just make one caution is that I can't name a single infectious disease that's been solved with herd immunity through natural infection. Through vaccination, yes, but not through natural infection. So I think the jury is very much out on that, but the seroprevalence studies are continuing here. In terms of the community health worker or trans health professionals, I think that, because the region is so uniquely disadvantaged in terms of the number of health professionals that we've had access to or that we've trained, etc., we've had to think more laterally for decades now about how healthcare is provided. So it's very routine for non-professional healthcare workers to assist with the responses. And yes, in South Africa, the revival of community health workers really, tracked the HIV pandemic. Although we had a very vibrant community health worker history in the early 20th century, actually. And obviously, the other shining example on the continent is Ethiopia with a healthcare worker extension program, which has really massively made an impact, particularly on maternal and child care in the region. And so I think it does challenge the paradigm that we think that healthcare is restricted to health professionals and to health services, and it's everybody's business, really. I think the second difference between Africa and the rest of the world is there's a much more collective culture in Africa. And communities understand things collectively. It wouldn't, for example, be really sensible to do contact tracing and follow up individuals per se without following up a household. So there's a very different philosophy that underpins the way that communities work. And in part, that's driven by poverty. That's driven by the fact that those networks have to be so strong because so many people are living in very desperate circumstances. And so those networks are strong so that people can survive from day to day. And so I think that has played a really important role in understanding the need. I mean, we certainly haven't been perfect. There's been a lot of people who haven't wanted to observe restrictions, etc. But I think that there's been a remarkable number of people who've understood that this is no one is safe until that everybody is safe. So I think that is a difference. It's a less individualistic society.
Thank you very much. Obi.
Yes, I'm going to pick up right off where my colleague just left off. In Africa, in the West, people say I am because I am. My house, my degree, my career, my reputation. In Africa, we say I am because we are. You have that degree because your family clubbed together and paid for it. You live in that house because you grew up living in a large household. Therefore, our natural bonds towards each other are much stronger, and our sense of being our brother's keeper and community is much stronger. I suppose one of the questions, on another hat, I do some economic analysis and some other stuff, but one of the questions I've always asked myself as an economist is the price of economic development the breakdown in society? Now, this is more of a philosophical question, you might say, but now we see the public health consequences of it. One of the best HIV management programs in the world exists in Uganda. A colleague of mine, Dr. Matalado, told me about how they handle HIV in Uganda. And I'm sure my colleagues from South Africa would probably have similar experiences. The entire family knows your CT your cell count. The entire family knows what's going on. It's a family problem. It's not an individual problem. And I think because of that, we see the benefits, if you like, of poverty. As my colleague pointed out, it might be because we're poor and we are more interdependent upon each other. But, you know, I try and say hello to somebody at the bus stop in the UK and they look at me as if I'm about to rob them. And it does bring a wry smile to one's face every now and again. But the point of, you know, just looking out for your neighbor, there have been some very interesting COVID-specific manifestations of this in places like Kenya. In some communities in Kenya, people in communities have clubbed together and moved all the grannies into one house where they're cared for, and then everybody else is living elsewhere. These community-based solutions feed directly into our willing ability to use community health workers, as Lara was saying earlier. Ebola was fought in Sierra Leone by close to 40,000 people. Now, the majority of these were not experts, social mobilizers, students, and young people, most importantly, young people, that took responsibility. And even as we have COVID today, that's one of the things that is happening. As I said earlier, what is different about Africa? We are yet to have a scientific answer about whether the virus, and that's again, not my lane, whether we have there's some sort of scientific reason why we seem to have milder clinical presentations of the virus in Africa. But what we do know is that the response in Africa has been very different and more community-based, and also has harnessed all of the little that we have in the public and private sector and using people. I emphasized this point earlier. Now, on information, I mean, I think that both my colleagues have spoken about that, so I won't belabor that point, but on information, my big point is the message, the messenger, and the media. Let me throw this question out. How many people who are listening to this or watching this webinar have ever been to the WHO website? Not many. As an expert, you have. I have. But how many people, young people today, get their news from WhatsApp? In many parts of the world, I mean, look at the information crisis over COVID they have in the United States. Many people don't watch CNN unless they're anti-President Trump. They don't watch Fox News unless they're pro-President Trump. They watch InfoWars, they listen to Rush Limbaugh. Where is the public health messaging on these channels? We haven't been able, the expert knowledge has not been disseminated in the channels that it should have. Where is it on Instagram? Where is it on Twitter? Where is it on Facebook? And no, don't tell me it's on the WHO handle, please. To me, if I was a policymaker faced with the problem of COVID from get-go, I would have called the marketing companies, the advertising companies. I would have sat them down with my scientists, and my scientists would have given them the messages that they want disseminated and the behavioral changes that they need. And I would have given these people, blown the whistle on them and said, go, make it happen. Similarly, on the logistic problems, I would have brought in the logistics companies, I would have brought in the armies, and I would have asked my doctors and my experts, what do you need, where, by when? And I would have tasked these people to deliver it. On community health and community work, we cannot, people are not stupid. And as I said in my introduction, a viral response is fundamentally about human behavior. We think we are faced with a problem we cannot solve until we understand that we have to drop on the virus, which is it needs us to infect each other. If we stop, it stops. But that is the one thing we haven't put enough effort into, and bringing communities into this process is fundamental to getting it fixed. Lara made a very important point that a lot of people do not necessarily think about, which is that these viruses act as force multipliers. People are not tracking how many more people are dying from malaria or from other things as a result of COVID. During Ebola, we tried to start to track this, because you will find that the fraction of people killed by Ebola is dwarfed by the actual number of people that are killed by other pathogens that we're readily able to treat. But what these viruses do is their first attack, the first set of victims, is really what you would call a diversionary feint attack. Because their actual intention, if you like, I started by saying we must treat them as thinking beings and not think they're just inert. The first assault on patients, first set of patients with a new virus, is really just a feint, a diversionary attack. The intention is to infect unsuspecting healthcare workers. Once the virus does that, then everybody is scared of going to hospitals. Doctors are scared of patients, and patients are scared of doctors. Then the main assault starts. And this is why informing, equipping, and protecting our frontline healthcare workers is perhaps the first, alongside informing the public, perhaps the most important aspect of a viral response. Now that then cascades downwards in terms of levels of engagement of the community until you get to community health workers. When we come to deploying vaccines in Africa, I would hope that we again leverage what we have done in terms of using community workers in order to fight Ebola, in order to fight COVID. We also again try to leverage these people in terms of the vaccines. We need to understand, I read somewhere that you're going to need something like 8,000 jumbo jets to deliver vaccines around the world. We are facing the largest logistic operation that humanity has ever had to contend with. And in each country, that problem will be present. For Africa, let us not rest on our laurels and say we've done well with COVID. Let us now start to say, well, how are we going to kick the door down and get access to these vaccines? How are we going to ensure that we have a place at the table in their development and deployment, in the research and the testing and the manufacturing? But let us now, African policymakers, at the Tony Blair Institute, we're just completing a major paper on advising governments on how to roll out vaccines, how to deal with some of the misinformation that is flying around vaccines. But then what are some of the debates and the arguments around the current model for global public health, which requires Africa receiving vaccines from people and not producing it itself? No sort of global health security, if you like. Policymakers need to start thinking about this now. And when they do, they will find that they have to, again, rely on local communities. And Lara made the point, don't forget, you still have to immunize for polio, You still have to treat pregnant women. You still have maternal health care issues to deal with. We cannot allow COVID to make us turn our heads away whilst more people die from some of these other clear and present dangers. Again, it's the same thing with lockdowns. In Europe, they introduced lockdowns to save lives. In Africa, we lifted them to save livelihoods. Because when you put down lockdowns, the impact on the healthcare system, the footfall into hospitals is significantly affected. You might find that you have 3 cases of COVID in your country, you've locked everything down, I don't know how many people you've saved, but X percentage more have died from childbirth issues because they couldn't get to hospital, because they have had heart problems, because they've had, so you need to balance these two things. And I would hope that the world learns from Africa, but that Africa actually gains self-confidence in relying on its tried and tested structures and systems that have seen us through.
Thank you, Obi. I'm going to ask three questions at once here, and if you want to answer or comment, all of you feel free. So the first one, Obi, I think it's from your colleague Marta. Marta, forgive me if I get this question, the sense of the question wrong. From what I understand it, you're asking, Obi, you talked about using those kind of market techniques, getting in the experts on marketing to change community behavior. And Marta's asking, how can you change that without people feeling like they're losing some of their rights? And I guess this is a broader question that also relates to lockdowns and that kind of thing. How can you convince people to change behaviors without feeling like they're somehow losing out? Zainab asked a question, again for the whole panel really. And this is something that it's very difficult, but has come up again. How do you think the governments in the West could have managed conspiracy theories around the virus and vaccines? And what could they do perhaps now to gain public trust? And Nasibu asks about vaccines. How is Africa involved in the development of a vaccine? Do African states have the capacity to develop vaccines? Or is this entirely a question of work from outside Africa? So please, anyone who would like to go first, just go ahead.
I'll start with Dr. Matalado's question. It's a bit like when you're at home by yourself, you could spend a whole day in your room, right? But the minute they say, go to your room, it becomes an intolerable thing to do. It is a question of whether you are losing rights to normal behavior or you're gaining a right to a longer life. And this is where the communication around the behavioral changes that you're asking people to do really matters. Are you telling people to stay indoors because you're issuing orders? Or are you convincing them that staying indoors matters? Then you don't need a policeman at their door for them to stay indoors. Do they want to be in their room, or are you sending them to their room? Bringing in the private sector is about understanding what private sector can do, but also understanding what it cannot do. Now, one of the key areas, for example, of private sector involvement likely is going to be with vaccine registries. We're going to need to know who has been vaccinated and who has not. And even in the rollout of the vaccine program, you might need more than one dose. So funnily enough, every problem offers a chance for, every tactical problem offers a chance for a strategic solution. Especially in Africa, we are very innovative, as Lara said, necessity. But as we come to issue out vaccines, we're going to have to start to answer difficult questions around how do we manage the information from those vaccines. The Global ID 2020 Alliance provides some very good guidelines around digital identity and how we can deploy those. Those should be considered now, even before the vaccines come out. What you'll find is that even though Africa has better clinical indications around this virus in terms of case numbers, hospitalizations, and deaths, Africa is disproportionately affected by travel restrictions around the world. And this is not based on any evidence, except on effortless condescension, which is where I'll leave it. However, if Africa is to reconnect with the world, it is going to need to be able to prove to the rest of the world that it doesn't pose a massive public health risk. To address the specific question around vaccines, there are about 100 vaccines in production. Of the 43 that are being tested, there's barely 3 that are being trialed in Africa. I already made the point around the sort of genetic importance of being able to test vaccines on various genome strands and whether they work. The current model for global public health, as I said, relies on Africa receiving vaccines. Gavi, the Global Vaccine Alliance, has managed to bring together something like 184 countries, rich and poor, to work towards ensuring that vaccine manufacture, production, and delivery is not based on affordability, it is based on need. Now, just the other day, we had China sign up to this. So we have 184 countries, which is the best example of cooperation we've had that we didn't have in actually responding to the virus. Now, we do have to ask the medium to long-term question. Currently in Africa, to answer the last question, it is probably only South Africa and Senegal that are anywhere near close to be able to produce the COVID vaccine. We have something like 7 countries in Africa that are capable of doing some sort of vaccine work, but there's a lot of challenges around it. There are challenges around investment. There are challenges around public commitment. There are challenges around intellectual property. There are challenges around technology transfer and IP rights and all of these things. There's a number of initiatives that are working now to try and unblock these bottlenecks, but we do need to change this narrative between the global north and the global south around a sort of supplicant recipient relationship. There has to be more of a partnership. Now, I would argue that we need to work around the IP rights to see our colleagues in South Africa and our colleagues in Senegal being able to participate more aggressively in testing, development, and production of the COVID vaccine. But even as we do that, we need to start looking towards, as I say, the strategic solution, the medium to long term. It's not a question of if, it's a question of when. Ebola was the first dry run we had. When COVID came, we started shouting, saying, you don't know what's coming. We've seen this movie before. It's going to end badly for you. Now we've got COVID. There would be something else. Let us pray that we don't have a virus with the infectiousness of COVID and the deadliness of Ebola combined together. We will not be able to produce enough vaccines in the current global architecture of public health that we do. We need a more diverse production platform for vaccines. So to answer the question, Africa is really practically shut out of development and testing and production of vaccines at the moment. We do not have the capacity. The lead times that you need are very long, but our colleagues in South Africa and our colleagues in Senegal are very likely going to be able to help us if there is global commitment and investment into bringing them in. But for us to be able to do this, we also have to convince the African people, the African governments, we have to work on the regulation, and we have to work on so many other enabling factors to make this happen. Thanks.
Thank you. Lara, would you like to comment on any of those questions?
Yeah, so I think I'm going to comment on the conspiracy theories and public trust. So I think that there is, there are obviously concerns in Africa. There has long been an erosion of public trust or trust deficit in terms of government. But I think the thing to recognize, and I think this is where a lot of high income countries have come short, is that there's no one who is expert in COVID. So there were suddenly a whole lot of experts, but in fact, we don't know what we're dealing with at all. And so there needs to be a greater modeling of honesty around those uncertainties and leveling with populations about what we actually do or don't know. I mean, it's been very concerning to see the reluctance to call out conspiracy theories as conspiracy theories. And here, in South Africa, there was a fairly successful closing down of myths and misinformation and fake news as soon as it came out, and people were prosecuted. At the same time, you can't leave the void of sort of cancelling conspiracy theories open. So you have to put into that space, information, replace that information. That means extremely hard work and actually producing that information in a way that's locally acceptable. And it also means being truthful about what we don't know and recognizing that this is the best available thing. I think what we've been battling with in South Africa is to move away from the extent of the surface spread towards emphasizing airborne transmission, and how, does that erode trust by saying that we got it wrong. But I think it needs to be turned around to say that we now know more. And so it's our responsibility to communicate that to people timelessly.
Great, thank you. Martin, can I
also
sorry,
it would also help if politicians wore some masks, for example, and model some of the behaviors.
I think we could do with a new set of politicians as well. In fact, Martin, I'm going to drop an extra question on you from Danny Rogers, if you also want to comment on the previous ones. Asks, are civil liberties and Western individualism hampering the fight against COVID-19? Or is the UK government on zigzag with its policies? So it's, we've touched upon it already on the panel, but if you can respond perhaps to that and to any other questions, that would be great, thanks.
Okay, so very briefly on the earlier points under discussion, I think a huge amount of this comes down to trust. Obe, you said earlier that lockdown was invented in Africa, yeah, and you referred to Ebola. But I think there's another interesting perspective on that, actually, that a lot of these mechanisms that have been being used, I think, probably quite effectively. The curfew, in particular, the confinement and isolation of cases, which many African countries have done a lot more energetically than in the West. So in countries like Uganda, Ethiopia, in the early stages, if you tested positively, you didn't stay at home. You were admitted. And you remained there until you had 2 negative tests, and anyone else in your household was put under strict quarantine and needed to remain at home, and this was supervised, and likewise for returnees to the countries. And this in certain countries has been kind of quite controversial. There was an interesting piece by Sylviane Diouf from Senegal, in fact, well, US, but she's got an honorary appointment in Dakar as well, in which she referred to these as being measures of the colonialists, and that there was a kind of cultural memory in many African countries, and this is not something that I would be in a position to judge myself, associating these measures with colonialism, military medicine, and there being a rather kind of tinged odor to them, which would be very understandable if that were the case. And I think what I kind of perceive by looking at the social media accounts of many countries that we've been following closely, and the way that they've been kind of communicating information, which has often been really progressive and really positive, is that some countries where there's probably been less political trust in the honesty and the transparency of the political leadership in the country at the time, they've experienced more difficulties, and they've perhaps been a little bit more heavy-handed about it, particularly in the early stages, but then they've stepped back when they realized that this was kind of really not working. Yeah. And frankly, you know, this is not an Africa-specific country. I think this is global, and I've been asked to comment on the situation in the UK. And I think this is also very political, where we started with a common front, you know, poor old Boris Johnson being admitted with severe COVID, apparently nearly losing his life, a lot of national unity, cross-party, you know, agreement about the measures that were being introduced. And how that has all fallen apart. In particular, I would have said over the last 6 weeks, with in effect rebellions of regional government saying, you want us to implement this public health control measure, you provide the funding that creates the mitigation and ensures that we don't have the, you know, huge negative impacts that will otherwise occur. And I think this is a really serious and concerning development. And I think it's in a sense for me a kind of false notion of localism around how you communicate, because local government is highly political as well, and it's often conflicted with the central government. We're seeing that in Zimbabwe at the moment, big time, with the MDC running the political administrations in Harare and Bulawayo, but the government being very firmly kind of ZANU-PF. And I think we're seeing a little bit of that in the UK at the moment. Who's trusted most? Local people are trusted, community health workers are trusted. In the end, the messages that come from them and are communicated directly are, I think, going to be most powerful. And coming back to the UK situation, it's our lack of community health workers. We used to have them, it unraveled, we haven't replaced that. At the moment, people are receiving kind of disembodied advice from somebody they don't know over a computer about how they should change their behavior, and they're very confused and they're distrustful, essentially, of these messages that have come through. I'm not sure that there's much that we can do about that at this stage, but there we are. A final very quick point on the kind of local production issue in Africa. I think this is hugely important, as you say, Obe, in global health terms. I think for COVID-19, for the medium to longer term, as you say, but it's important that we don't forget this and we don't leave it on the back boiler, that amongst the many kind of recovery issues that I think are going to be required in the continent, building back better and in that particular area is important. Because if you look at the testing, the countries that have done particularly well around testing are all of those countries that have made significant effort, investments in biotechnology actually before the outbreak took off. They haven't only been better at having more laboratory infrastructure and deploying that, they've been better on innovations. So countries like Ghana, and Ethiopia introducing, for example, pooled testings of samples very early on and being able to increase their capacity at that way, and the use of low throughput but rapid testing, HIV and TB technology transfer to COVID-19 testing again. These countries, Rwanda being another excellent example. It hasn't necessarily been the richest countries in sub-Saharan Africa, but it's been the ones that had made the most solid investments in biotechnology early on.
Thank you so much, Martin. We're out of time. I think there's a lot more that we could talk about. There's so much in what all of you said. So thank you everyone for who's attending and for the questions. You know, if we were there in person, there would be a round of applause right now. But you can imagine it's taking place. So thank you so much, Lara, Martin, and Obi.